I am given by Joe titles and questions and direction. So hopefully I cover what you want to hear. But there are a number of questions, and I've put in a few examples of what we know or what we are thinking about as we go along. So there's many more slides than normal, I'm afraid to say. Right, let me see if I can move this on. So that was the title. This is what you have requested. What happens during TTP. I'm not going to go through the whole explanation of TTP again. What are the blood tests for, and how does a relapse possibly present? So when any of you have originally become unwell and are presented to hospital, it's not immediately obvious all the time that it's TTP, the diagnosis is TTP. And in fact, there's many conditions that can present with similar features, something called a thrombotic microangiopathy. And what that means is it's the blanket terminology for patients with a low platelet count, hemoglobin that's reduced, and the blood film findings that we would see in TTP, but they're also seen in all these other conditions. And the reason that that's relevant is that we need to exclude or consider those other conditions very quickly in our process of diagnosing or excluding TTP. Now, it's obviously easier to think about TTP because we've got the ADAMTS13 tests, and if they're extremely low, that would be in keeping with acute TTP. But there are loads of other laboratory parameters that we take, and you will know that because of the number of blood samples we take. So what I'm going to go through very quickly in the first part is rationale for everything that we do, why you have so many bottles of blood done. I think this does individual ones. Yeah, so one of the first ones, apart from the full blood count, we look at your kidney function, and we need to see if your kidney has been affected by the TTP, and it's not infrequent that it may, and pretty quickly with treatment. But if the ADAMTS13 is not low, we do need to consider other conditions. So I'm thinking here of the diagnosis of a thrombotic microangiopathy, not just TTP. So we look and check the urine, we dip it to see if there's blood, protein or white cells, and we do something called a protein creatinine ratio, which we also do in clinic for TTP patients. So we want to see how much protein is leaking.
Marie, can I just stop you quickly? Could you turn your volume up or speak a bit louder?
I'm slouching in the back of my chair.
Oh, sorry. Thank you.
Oh, wait a minute. Now I'm pressing too many buttons. Let me just come out and see if it is max. Oh no, it's not. Sorry, I turned it down earlier because it was so loud. Okay. Is that better? Can you hear me better? Is that better, Jo?
Yeah, a little bit. Thank you.
So the next thing we look at is liver function tests, and there's a number of reasons for this. We look at the bilirubin, which is one of the parameters that kind of gives you a greeny type plasma, because it's an indicator of how much hemolysis. But we also look at the other liver function tests. So the ALP here is alkaline phosphatase, and that typically excludes or looks at if the liver's obstructed. And the AST or the ALT looks to see if the liver's been damaged by what we call ischemia. So if you've had little blood clots in the liver and it's been affected that way. We don't normally see too much damage from the liver function tests. The bilirubin's often high, and you will often know that because you may appear a little sort of yellowish. So the other types of biochemistry tests we do the troponin, which is a marker of heart involvement or heart damage. So the troponin is normally done for patients who have heart attacks. You guys don't have heart attacks per se, but it will release the enzyme if there's damage to the muscle, so inside the muscle. And that's a very good marker to tell us the degree of severity of the TTP. So we usually up our game and give you even more treatment if that's raised. We check thyroid function because, you know, having a low thyroid function is not uncommon. The CRP or C-reactive protein, some of you may have been admitted to hospital with a temperature, and this is a useful test to tell us that the temperature is not related to an underlying infection, or indeed that you have got an underlying infection and we need to treat that concurrently. Complement level 3 and complement level 4, it's more appropriate for us to do that when we're thinking about another condition called HUS or other autoimmune diseases such as lupus. And for men, we look at the PSA, the prostate specific antigen. We do B12 and folates for two reasons. One, the folate level is reduced because you're breaking down your red cells really, really quickly, and you can use up the supplies. And many of you will remember being given folic acid in hospital. But we do B12 because sometimes it can mimic the presentation of TTP, where you can have a low platelet and anemia and evidence of hemolysis, so increased bilirubin and LDH. And that's always quite embarrassing that someone gets exchanged because of severe B12 deficiency, but it's not common in this era because so many foods are fortified. We do a virus screen on admission, and there's a number of reasons for that. So we do the hepatitis A, B and C and HIV, and we may or may not do the viral load for HIV. So we do it because we're going to give you a large volume of blood products in the form of plasma exchange. But also you will have some red cells during the time, so it's good to understand what the baseline virology is. Secondly, we do it to exclude that a patient doesn't have HIV precipitating TTP. So, and then we will go on and measure the amount of HIV virus and give treatment for that virus as well as treating the TTP. If in other situations, less relevant to TTP but other TMAs, such as people that have stem cell transplants, have similar initial blood parameters, we would do other types of viral screens such as adenovirus and CMV, and probably in this era COVID-2. So we take samples and we culture them in blood cultures if you come in with a temperature, to make sure that we don't identify any bugs which could be aggravating or precipitating the TTP. And if we've excluded TTP and we're looking more at an HUS type situation, we do genetics almost for types of E. coli that can cause HUS and pneumococcal antigen in the urine. With regards to doing types of imaging, we don't do this immediately. We should be getting on and sorting out treatment. However, we do an ultrasound of the tummy to look at the size of the kidneys and if there's any level of blockages and the size of organs. Again, we do it for TTP patients, but it's particularly relevant for HUS. We do MRI scans. Generally, we try to get them done before a patient's discharged, just to see if there's been any evidence of small little blood clots in the brain. And we do a scan of the chest, abdo and pelvis, mainly if we want to exclude that there's no underlying cancer causing the presentation. So investigations for the heart, you will get an ECG at the bedside, and we usually do an ultrasound of the heart or an echocardiogram quite early on to have a look at the degree of heart function. And in general, the heart is functioning pretty well, but we like to have that as a baseline, particularly if there's any worry with the high troponin levels that I described earlier, or any minor changes on heart tracing, the ECG. So that's all the blood tests. Has anyone got any questions through Joe about the blood tests? Do you want me to answer them now, Joe, or just carry on?
Shall we carry on and then we'll do all the questions at the end? And if people have got questions, if they pop them in the chat, and then I'll read them out. Is that okay?
Yeah, it's fine by me. So as you can see, we do quite a lot of investigations at presentation, and I haven't included obviously the full blood count and ADAMTS13 testing, which I've suggested as a given. In follow-up, we do the full blood count, the kidneys, the liver, an LDH level, which is a good marker of cell breakdown. It's a good screening test. The ADAMTS13 samples, and then eventually we will do the hepatitis screens. We will redo them later on when things have all settled down. And that's the mainstay of blood tests that we do later on. We may or may not do other autoimmune tests if there's any suggestion of another autoimmune disease that could be causing some of the ongoing symptoms. So I've been given a whole list of questions that I'm going to go through. Some have got other slides attached to them, read data, but most of them discussion. The first one is there any research or findings related to quality of life once diagnosed and treated with TTP, and what could be done to improve quality of life? Again, I think we've discussed it before, and I think it's very important that we recognise as the medical profession that we have done little in the long-term follow-up for patients with TTP. In our defence, we have spent a long time trying to treat the acute condition. And obviously when I started off, getting through patients through acute TTP was far more problematic perhaps than the treatments and the protocols that we have now. However, there are a number of groups internationally looking at quality of life. I would say that they're primarily focused on depression, anxiety, and issues with regards to memory loss and poor recall. But we do know that at least 50% of patients have depression after clinical depression after acute TTP, and certainly anxiety features within symptoms that are displayed, and we have to take these very seriously. And I think we're going to be doing that once we achieve the national service, primarily because part of it includes having a clinical psychologist working alongside us. So we really do recognise that that is affected. However, it doesn't take into consideration all the parameters of quality of life that we should be addressing, but I think that they will come over the next 2 to 3 years. Next question. I was diagnosed with TTP a year ago when I was 12 weeks pregnant. Now a year later, thankfully with no relapse, I would like to know what the chances are of having a relapse in case I get pregnant, and what are the main things I need to check and what I need to do to have a successful pregnancy. Well, firstly, I don't know if it's congenital or acquired immune-mediated TTP, but I'm assuming it's immune-mediated. The most important thing before embarking on pregnancy is to ensure that the ADAMTS13 level is essentially normal, and that may mean some treatment before embarking on pregnancy. With that said, it doesn't mean that the levels can't decrease in pregnancy, because that's the normal physiology. So with pregnancy, the protein von Willebrand factor becomes very high, and the ADAMTS13 in normal women, and by that I don't mean that TTP patients aren't normal, I mean women that have not had TTP, their levels of ADAMTS13 decrease as pregnancy proceeds. So it's really important to ensure you optimise outcome and have as normal as ADAMTS13 before you proceed with pregnancy, and thereafter it requires monitoring not only of your routine blood counts, also the ADAMTS13, which will depend on what the levels are. It will require more frequent scans and being part of a high-risk obstetric clinic, which all hospitals now have, and ensuring that if there's any suggestion that there's problems, so there could be pregnancy-related problems such as preeclampsia or just high blood pressure, or if the ADAMTS13 levels start to decrease, that pregnancy is babies delivered at the first safest opportunity, which will generally be within the 3rd trimester. But it's quite a big topic, and it needs to be an individual protocol almost for patients. So why do so many patients seem to get extreme fatigue and joint problems post-TTP even when the bloods are good? And what can be done to help or combat this? Firstly, aches are significant symptoms in some patients after a diagnosis of TTP in follow-up. Joint problems I've not seen per se unless it's associated with some other type of autoimmune disease. But please be mindful that you do get large doses of steroids in hospital, and that can affect, for example, the hip joints or the back joints. So sometimes it's worth, if these are problematic, getting a DEXA scan to see whether you've got any osteoporosis, because the steroids will accelerate that. But which I hope will give you some understanding of what we're trying to look at related to this. This is one of the questions that it's related to. What symptoms should we look out for in terms of relapse, especially individuals who didn't get the typical rash or bruising? That's a very, very difficult answer to give you all, because you will have presented with a situation which may have been an extremis, and while you do have a relapse, same situation. Similarly, the little red dots and the bruising are usually only when the platelet count is quite low, and while some patients look for that and we can organise blood tests if they see it, I can't actually tell you per se what symptoms you're going to get, because it will very much depend on whereabouts you are on the scale of reduction in the ADAMTS13 and decrease in the platelet count. All I can say is if you don't feel right, you're not sure what it is, increased lethargy, certainly headaches seem to be a predominant feature in an impending relapse, is to go and get some bloods done sooner than you would normally do for a clinic visit. If the original episode was triggered by an infection, is it likely to be the trigger in potential future episodes? The question of infections is very difficult. It's not uncommon on admission that patients feel like they've had a temperature, they feel very achy and virally, but actually diagnosing a specific infection is not common. That said, I've already explained about HIV, which is a very, very small percentage of patients, and tooth infections, this is anecdotal, seem to not be infrequent, but actually having a confirmed viral infection or bacterial infection is not common, even with the initial episode. It doesn't mean it can't happen, I'm just saying it's not common. That does not equate to any further infections likely to precipitate a relapse. And the reason we can think about that is because over the years you will or will not have had viral infections, flu, tooth infection, finger infection, and you won't have had TTP. But I'm hoping that you will be followed up satisfactorily, that if you don't feel right, you can go and get a blood count to ensure that you're not having a further episode. When first diagnosed, there is a period of time when the doctors seem extremely interested in every ache, pain, headache and energy level. And at a certain point, that all seems to suddenly stop. And while the symptoms may exist, the doctors stop being concerned or interested. What triggers the change in levels of concern? And how can we become aware of what is of concern and what constitutes the new normal? In defence to the medical profession, I think sometimes not discussing the symptoms, in part, is because of what I've said before, where we have spent many years focusing on an acute episode, and in part not knowing what actually causes these symptoms, which low energy, headaches, aching is definitely a feature in TTP. And we know from congenital TTP patients, those patients that are born with TTP, treatment cycles, they may feel these symptoms. And if you increase the frequency of treatment, those symptoms can be reduced significantly, and we have definitely demonstrated that. I've got some more slides later that I hope will help to answer some of these queries, but they're very, very important. And I think the reason that we don't keep discussing them all the time is because we don't know what causes them and we don't know how to treat them. But I think that will change. So at what level does an ADAMTS13, at what level ADAMTS13 do you need to have for a relapse to occur? It's the same as with an acute episode. It's less than 10% or 10 international units per deciliter, and often it's less than 5. So it's exactly the same as an acute TTP episode. Can you have symptoms while your ADAMTS13 is falling? And will there ever be research on all the symptoms we get in remission to see if we can predict an episode? Again, very, very important questions, ones that we have been considering. The only way that you can gather information is to collect information that we can share with you. And certainly now that we're doing the yearly forms that we fill in, and treating more and more patients electively, and by that I mean giving Rituximab when the ADAMTS13 level is dropping to get it back to normal, has it become apparent that the symptoms that the previous question holder has discussed and the ones that seem to become more apparent when the ADAMTS13 level is falling is a real phenomena? And again, it goes back to our understanding of congenital TTP, where the symptoms are not dissimilar. So some patients have no symptoms at all. So be clear that it doesn't happen in everyone. But other patients feel more tired, they have headaches, they may have funny visual auras, kind of migrainous type symptoms, and they will have their ADAMTS13 checked and it is reduced. We will be doing more research, particularly in this very important area, I promise you. So rather than wait until your ADAMTS13 level is low enough to have 4 doses of Rituximab, could you possibly give 1 or 2 doses just as it started on the downward trend? And would 1 or 2 doses at the beginning be sufficient to get your ADAMTS13 level up before it got very low? Very fair question. However, there's a number of problems with that. The first is we don't have the information to be able to practice like that. So to do that could cause more harm than good. And there are some places where the ADAMTS13 level isn't measured and patients are just given Ritux every 3 months, for example, based on how many relapses they've had in the past. That's not to say that's the wrong practice, but there's no evidence base around it. And we have to practice to some level evidence base. Furthermore, Ritux isn't without its side effects. I mean, it's a relatively easy therapy to give compared to things like steroids, but I'm sure many of you have had reactions. And in the longer term, not that we're not doing it, but if you keep having Rituximab, every 3 months for years and years and years, it will drop down some other parameters which will result in you having an increased risk of infection. So until we have data that suggests that we should be just giving it every few months, 1 or 2 doses, I don't think that we can advocate it at this stage. However, what I do think we need to address is the level of ADAMTS13 at which we should be giving treatment, and that's become quite topical. Again, there's no evidence base, but I think we need to be more mindful in the future at what point we start giving treatment. And the reason I say that, I'm completely not having ADAMTS13 really low before treating, but we do need the evidence. But what we do understand is there's many conditions such as stroke, heart disease, diabetes, where the ADAMTS13 and the von Willebrand factor predict those with more severe disease. So those with a lower ADAMTS13 activity and a higher von Willebrand factor are more likely to have a stroke, heart attack, and diabetes, but that's in a massive population. And by low ADAMTS13, I don't mean really low, I mean in the lower part of the normal range, but it's used because. So there is some evidence that suggests that we need to be considerate about the level of ADAMTS13 if we translate that back to TTP patients. This is a really important paper that I want to share with you, just so that you appreciate that we are considering what we do very, very seriously, and appreciate also that for many years giving elective Rituximab to normalise ADAMTS13 levels and prevent acute relapse was frowned upon, even though now it's relatively standard of care. But this group from New York have looked at the incidence of stroke in patients with TTP compared to just a standard population of patients. And what they found was the patients more likely to have stroke had lower ADAMTS13 levels. Now, this is not just a one-off measurement. This is over months to years that their ADAMTS13 levels were significantly reduced, and they weren't part of an elective therapy program. But essentially, the higher your ADAMTS13 levels are, in the longer term, the reduced risk of other complicating factors. So I had my first acute TTP episode in December 2019. Can I have my flu jab within a year of an acute episode? The answer to that is yes. This has been, again, quite a topical question, and the reason we say yes, no, can I just show you a little bit of science behind our madness? So Rituximab acts on B lymphocytes, and B lymphocytes are important for a number of different reasons, one of which is if you present it with an antigen. Now, the antigen could be an infection, or that antigen could be a vaccine. And when you stimulate a B cell with a vaccine, it produces activated B cells, which is what you want. If we're going to if we're going to reduce your B cells right down, it doesn't matter how much vaccine you're going to give a patient, you haven't got any cells there to produce these antibodies. What are unaffected are antibodies previously made. And you will have made many hundreds and thousands throughout your lifetime. But there is a period after Rituximab where the B cell numbers, and we measure that by CD19 levels or CD20 levels, are going to be so low that it's going to be pointless giving you a vaccine, because you've got none of these for the vaccine to act on. And usually they start to increase between about 6 and 12 months. And I mean, we certainly measure it every time patients come to clinic. So you need to check with your own doctors as to when they would advise you to have a vaccine. And that's usually based on these particular levels. So I hope that's just cleared up a little bit why we say you can't have it, you can have it, it just won't be effective. I had my regular flu jab 3 weeks before my first acute TTP episode. If vaccination is a trigger, would you see an acute episode within 3 weeks? I had atypical migraine with aura 1 week after the flu jab. I presume this was due to my ADAMTS13 dropping. I mean, it all sounds very temporally associated. It's very difficult to know at the rate at which the ADAMTS was dropping. And while vaccines can stimulate immune conditions, it's not really a common trigger for immune-mediated TTP, funnily enough. It can aggravate congenital TTP type. In this particular occasion, that the vaccine was associated with the acute TTP episode, and nor does it mean that you shouldn't have vaccines in the future. It just means that you need to be monitored a bit closely around that time. Are symptoms of subsequent acute TTP relapse the same as previous acute TTP? Well, I thought I'd show you some work done from my colleagues in Ohio who looked at exactly this question. And I've highlighted the relevant ones for you. So, clinical presentation, having CNS symptoms, so headaches, migraines, are relatively comparable. There's not what we call a significant difference between whether you have an initial or a relapsed episode. And that's pretty similar for nausea and vomiting and petechiae and bruising. And as you can see here, only about 50 to 60% of patients, as the previous question that came up, of patients actually have these little red dots and the bruising. Is there much difference between the platelet count at the initial presentation and relapse? Well, by statistics, yes, there is a difference, but in reality, whether it's it may, to be honest. ADAMTS13 activity, as I've said, is relatively comparable whether it's an initial or a relapse. It's going to be very, very low. But let's have a look at the amount of treatment. Generally, a relapse requires, or they demonstrated less treatment compared to an initial episode of TTP. But even though these numbers of 10 for an initial episode of TTP and 5 for a relapse, you'd think, oh, we only need half the treatment. That's not what it's showing, this data, because this is the significance values and it is a non-significant difference. And the reason for that is that's the median, but there's a massive range. So some patients need a lot of treatment even in relapse. And the number of patients who needed more than 5 plasma exchanges to remission is less in the group who relapsed. So the clinical response rates between the two groups, initial versus relapse, is comparable. There's a comparable risk to having an exacerbation, that is, your platelet counts drop during the acute TTP episode. But this is important. So there's a difference in those who have relapsed TTP. They're more likely to have what we call refractory disease. That is, it's harder to treat. And that makes sense, really, because having multiple relapses almost declares yourself as having, up and down ADAMTS13 levels, and it depends how long it is before you went in. So, in summary, you may have milder symptoms if you present with a relapse, but it cannot be guaranteed, and we cannot take for granted the response rate. So we have to treat all relapses as if it was the initial episode. Lifestyle changes or actions patients can take to improve ongoing symptoms. I mean, nothing really up and above what one should be doing as part of normal lifestyle changes, particularly when you're faced with an acute life-threatening disorder such as TTP. But improvement of ongoing symptoms is very difficult, and many patients have presented different ways of dealing with this. The first thing is to acknowledge if there's any anxiety or indeed perhaps depression, and talk about these and get help about them. They're really important because you're not going to improve your general well-being unless they are addressed. And thereafter, rest, vitamins are good for you, all the normal lifestyle advice that one should follow. And that's it. I think I spoke the course of an hour. Any questions?
That was brilliant. Thank you ever so much. I have got a list of questions, so I'm going to fly through them and I'll try and skip over ones that I know you've answered. So one question is about the COVID vaccine. As and when we get it, are we likely as TTP patients be able to have it?
Yes, except for the reasons that I've said about the recent treatment.
Next question. Can taking antibiotics bring down the platelet number?
So it can do, but necessarily produced by the drug that can sometimes make your platelet count drop.
Okay, brilliant. We've got a question now. This Francois is with us from France, which I think is quite nice when we get people from overseas joining us. And the question is, you talked about CRP value. So if that's when you have a fever, would that be high or low?
High.
High. Lovely. Go on.
Sorry.
If you've got an infection. Yeah, if you've got an infection, okay.
You can have a fever as part of TTP, which is not infective. So you can get it as like an inflammation type thing.
Yeah, okay. So moving on to other questions. When would you do the hepatitis HIV testing after an acute episode of TTP?
Usually leave it a few months and then do it then, just to let everything settle down. So what we sometimes see, and it can be problematic, is if you get plasma before, particularly octoplasm, before we do the testing, so that there's automatic antibody transfer, which is fine. It doesn't mean you've got the disease, it's antibodies that transfer. But when we get the test results back, you can't tell if someone's previously had an episode of hepatitis. So sometimes we put you on lamivudine while you're having your rituximab, and then after usually 2 or 3 months we'll recheck the virology, and then it usually all goes back to negative, and then you can stop the lamivudine.
Okay, brilliant. Are there any papers out about depression and anxiety and quality of life?
There's not much about quality of life per se, but definitely about depression and anxiety. There's not a whole host of them, but it's definitely recognised.
Okay. When you're having a relapse, do you get the same symptoms as the first time?
Depends.
Okay.
Impossible to answer.
Here's one for you. What's the oldest known age for initial diagnosis of ATTP? And go on.
93.
93, my goodness. And are relapses less likely if diagnosed at an older age?
Not necessarily. And the reason for that, although we haven't had multiple relapses in patients in the older age group, they have generally more severe immune disease. So they're often harder to treat if we compare it back to other types of immune diseases. So I don't think we can sit on our laurels and just assume that they'll never have another episode.
Okay. Can you take HRT if you've had TTP?
Yeah, so we like to not give massive doses of estrogen because it can upset the ADAMTS13 level. However, you've got to be a bit more pragmatic. I mean, there's other types of therapy that one now can use for HRT. But if someone's really suffering, it's, have the HRT and we monitor the levels.
Yeah, okay. How soon after an infection or insult or new drug, whatever the trigger is, can TTP relapse? Would it be 5 days or 14 days or months?
There's quite, a couple of weeks. It's not usually longer than that. If you consider your cells before you came in, it's usually the couple of weeks before you came into hospital that you felt worse. Yeah. What we don't know is the time preceding that where things started to not feel as good as they were before, but it's not usually a long lag time.
Okay. If you were diagnosed with TTP in spring of this year and are currently taking mycophenolate, have I said that right, long term, should you be shielding?
So it's under the immunosuppressives, but it's moderate risk, a bit like the Rituximab. It's not heavy immunosuppression such as somebody having chemotherapy.
Okay. Is there a central collection point globally for a big data collection of TTP patients worldwide?
No.
No. Okay. That's something to aim for, isn't it? Can you imagine?
I mean, we can't even go global.
Yeah. If ADAMS 13 is not low, does this mean you don't have TTP and it's something else on the spectrum, even though plasma exchange worked as a treatment, no rituximab given?
Correct.
Okay.
So we do give it for other types of the thrombotic microangiopathies.
Okay. Okay, do you always give 4 rounds of Ritux in 4 weeks? In France, you only get 1.
Listen, it's the UK protocol. I can't comment on other
Yeah,
countries.
lucky France in my case. I didn't like that drug. um, is the
I didn't think
TT gone?
I didn't think they just did one dose because certainly when they give their elective therapy, they give 4 doses. So I suppose it depends where in France you're being
Yeah,
treated. I don't think
it's
it's standard over there, to be honest.
just like the same in England. I think it depends, doesn't it, to some extent. Is the TTP population typically found in the lower ADAMS 13 subset of the general population?
I don't understand. What do you mean? Explain that to me. Sorry, I don't understand what you mean.
That was from, okay, so Gabriella, stick in the chat, please. Another way of phrasing that, and I'll just have a quick squiz and see if we've got any more because we're coming towards the end. So, so aside from the flu vaccine, what's the advice for having the I can't say. Why do everyone giving me big words today? Pneumococcal. That's the pneumonia vaccine, isn't it? Yeah.
Yeah. It's fine. Absolutely fine to have it.
Okay.
All kids get it.
What's the standard gap between relapses?
Oh, really, there's not. There's almost 2 peaks. So the first peak would be, 18 months, 2 years after the initial episode. But actually, there's a kind of a second peak sort of between about 7 and 9 years. So you had to see that patients are followed up long term and continually have these levels measured.
Can we take ibuprofen?
Yeah, if your platelets are fine.
Yeah. Does everyone relapse? I think no. Okay. I think we're all done on the questions. So I want to say a huge thank you to Professor Scully for your time and for listening to all our questions and for taking all my emails in the run up to these events where I throw things at you. I just want to cover off a couple of little bits of admin. You're welcome to stay for this, but I just want to say a couple of things. So Kaplan, NICE haven't made their decision yet, but we are hoping that we might hear something in the next 6 weeks. Scotland, the Scottish Medicines Consortium did approve Kaplan for use in Scotland, which is excellent news. And I've made sure that NICE know that Scotland did that, and they did that very quickly. And I know that others in this group have done that too. I want to thank everybody who booked a ticket tonight and who decided to make a voluntary donation. That will all be transferred across to the UCL charity once it gets downloaded from Eventbrite, and I will be sending out a feedback questionnaire as I always do, and I do appreciate if you have time to send that back. And the final thing I want to say on the admin wise is the distance aware badges. The little yellow shields with the TTP logo in the middle. I've still got some of those, and there are also quite a few at various hospitals around the country. So if you do want one, if you are feeling a little bit anxious about COVID and just want people to keep their distance, then you can find it on our website, www.ttpnetwork.org.uk, and go to the shop. They are free, but you'll pay a postage charge to have them delivered. Or if you're near UCL, they've got some. Liverpool have got some. Oxford have got some, and I think Cambridge have got some, and possibly somewhere else as well. But so get in touch if you need some. Bristol, yeah, I think is Bristol BTS or MBS? Do they do Bristol? Or do they do? Because I gave some to Lydia, and she was gonna send some round. So that's brilliant. Thank you once again, Professor Scully. We're so privileged to have your attention.
Thank you for listening.
Pleasure. Brilliant. Go and have your tea.
Bye bye.
Everyone have a good evening. Bye bye.